Well, welcome to my presentation for the Metabolic Wellbeing Masterclass. I'm Angela Hywood and I'll be talking to you today about Polycystic Ovarian Syndrome, a women's health condition that's very close to my heart because it makes up a lot of what I do in my clinical practice day to day. I love working with women with Polycystic Ovarian Syndrome because what we can achieve with them with natural medicine strategies, diet, lifestyle medicine, botanical medicine, and nutritional medicine is absolutely clinically remarkable. So I'm thrilled to be with you today and thrilled to share with you some background about this condition and then all of the incredible strategies we have to help these women flourish into healthy reproductive well-being with beautiful, healthy, normal menstrual cycles. So Polycystic Ovarian Syndrome is one of the most common endocrine dysfunctions in women's health when women are in their reproductive years. Now, really, there's a lot of debate. Does this fall into the reproductive medicine category or does it fall into the endocrinology category? Because one of the broadest problems with this condition is metabolic syndrome. And the metabolic syndrome derangements then have reproductive symptomatology associated with them. So really, it should be considered more like a polyglandular disease or disorder or syndrome. Now, two of the hormonal features of PCOS are high androgens and high estrogens coupled with very low progesterone. The features of this condition and the reproductive impacts are irregular menstrual cycles or oligomenorrhea or complete amenorrhea. So with both of those, because ovulation is either non-existent or very late, we're going to see extremely low to negligible levels of progesterone. So we see androgen dominance, estrogen dominance coupled with not insufficient progesterone. Now, PCOS affects up to 18% of women in their reproductive years. So it's a common disorder. Now, currently in the medical world, there's three major diagnostic guidelines for polycystic ovarian syndrome. The oldest of which is the NIH Statement of Diagnostic Guideline published in 1990. Then we have the Rotterdam criteria published in 2003, and then the Androgen Excess Society Statement published in 2006. So I think we'd all agree all of these diagnostic guidelines are getting pretty old, medically speaking. So to be positively diagnosed with PCOS, according to the NIH statement, you simply need irregular or absent menstrual periods, which doesn't really do a great job at differentially diagnosing it from hypothalamic amenorrhea, which are two very different conditions. The Rotterdam criteria requires a woman to have two of the three features, which is either high androgens, absent or irregular periods with cysts on the ovaries. So two of those three features. And the Androgen Excess Society requires the diagnostic criteria of two of the three symptoms. However, androgen excess must be one of the features for that woman. So either high androgens and irregular or absent periods, or high androgens with cysts on the ovaries. What we clearly see here is simply having like a sonogram and evidence of cysts on the ovaries is not a confirmed diagnosis of polycystic ovarian syndrome. And medically, this gets confused so often. I have girls come and say to me, I've had an ultrasound or a sonogram and I've got cysts on the ovaries and I've been told I have polycystic ovarian syndrome. And when I look at their blood work and we see no evidence of insulin derangement or hyperandrogens and they've got regular periods, I say, no, you've got simple cysts on the ovaries, but you don't have the full-blown syndrome. So what I'm saying there, just in summary, is ovarian cysts are not enough to confirmedly diagnose PCOS. Now, as you will see here, the biochemical evidence of insulin resistance or metabolic syndrome is not necessarily a part of the diagnostic criteria for polycystic ovarian syndrome. However, it's really important that this is investigated, because we will see it as a concomitant metabolic consequence or metabolic driver of polycystic ovarian syndrome in women. So it isn't a part of the formal diagnostic criteria. However, it's absolutely critical that we ensure that we look for it and test it, because insulin resistance and full-blown metabolic syndrome causes an enormous amount of derangement with our female hormones. So this is why it's very often talked about concurrently with polycystic ovarian syndrome. Now, some of the other major drivers of reproductive disruption in PCOS, from an integrative medicine perspective, we will always be looking at the impact of stress on the female reproductive system. Now, from my 25 years of clinical experience, and probably yours as well, I think we'd both agree that the impacts of high cortisol, so that true biological definition of stress, we know has a dire impact on pancreatic function, on flow of increased risks of metabolic syndrome, and certainly has a dire impact on the dysregulation of the female reproductive system. We also know that stress can induce more obesity and has an impact on insulin resistance. So obesity and insulin resistance needs to be looked at. Hypothyroidism has an impact on polycystic ovarian syndrome as well. And we know that hypothyroid function also causes very heavy menstrual bleeding, and heavy menstrual bleeding is a big feature of polycystic ovarian syndrome as well. So we need to cross-check their thyroid function. Inflammation is also a big disruptor of hormones for women. So we always look for inflammatory markers like C-reactive protein or elevated erythrocyte sedimentation rate. And where is that inflammation coming from? The inflammation is often coming from the obesity. So adipose tissue is very metabolically active and drives a lot of inflammatory mediators. But the inflammation can also be coming from diet and lifestyle consequences as well. So we need to look for it and manage it effectively. Immune dysfunction needs to be checked and assessed. And of course, one of the big ones with any female reproductive condition, but particularly PCOS, is we need to really explore into all the environmental toxicities that are endocrine disruptors and cause some pretty dire consequences with female reproductive health and wellbeing. So these are our BPAs and our plastics and our pesticides and our herbicides, things that we as integrative practitioners are very familiar with. Okay, now there's 4 different subtypes of polycystic ovarian syndrome based predominantly on the Rotterdam criteria definition. And this was proposed from looking at a study of 258 women with polycystic ovarian syndrome. So there's a phenotype called HOP, standing for women who have high androgens, irregular periods, and cysts on the ovaries. And that classic PCOS phenotype accounts for just over 50% of the PCOS population. Then we have a second phenotype, which is irregular periods with high androgens. So the HO phenotype. That accounts for approximately 30% of the PCOS population. Now, making the differentiation there that these girls don't have cysts on their ovaries. Then we have the phenotype where girls have high androgens and cysts on their ovaries. So that's called the HP phenotype, which accounts for just under 15% of the PCOS population. That's called the ovulatory phenotype. And then the 4th phenotype is the girls that have oligomenorrhea and cysts on the ovaries. So the OP phenotype. Again, accounting for around about 15% of the population, and that's called the non-hyperandrogenic phenotype. So that just gives you a bit of an overview of the percentages of the population of PCOS and how they would classically fit into the PCOS diagnostic criteria. So the androgenic phenotypes, compared to others, the androgenic phenotypes have higher levels of inflammatory C-reactive protein, higher fasting blood glucose levels, and more overt glucose tolerance testing, or worse glucose tolerance testing, and there hence an increased incidence of insulin resistance. They have an increased risk of dyslipidemia and metabolic syndrome. They have an increased incidence of non-alcoholic fatty liver disease and independent obesity and insulin resistance. And the correlation between testosterone levels and dyspareuria, or pelvic and bladder pain, and urinary urgency and nocturia plays into being a feature of this androgenic phenotype. So we can see the androgenic phenotype have a more high likely risk of all the metabolic syndrome complications and inflammatory mediated complications. So that's the subtype that we really want to focus on a lot of metabolic work, as I will show and explain with you today. So women with PCOS have an increased risk of developing overall cardiovascular disease, including the onset in adolescence. They have a higher risk of type 2 diabetes, endometrial cancers, premenopausal breast cancers, and interestingly, research is now showing us these girls have an increased risk of anxiety and depression. Again, showing us that the HPA axis, the hypothalamic pituitary adrenal axis, plays heavily into the symptomatology of polycystic ovarian syndrome. So the signs and symptoms that we will often see as well, the signs and symptoms are very broad. There's a wide range of them, and every patient will present slightly differently. So what we want to look for is, is there ovarian dysfunction, irregular periods or absence of the periods? So irregular menstruation or complete amenorrhea. Is there evidence of high androgen, so hirsutism, virilization, acne, weight gain, and is there cysts on the ovaries? We know that women with PCOS often experience a reduced libido as well as a consequence of the hormonal derangement going on for them. So often girls will come into our office pre-diagnosed with the condition, but that means we need to actually be looking at their blood work and figuring out what category of PCOS they sit in for us to then develop a really good and thorough holistic strategy treatment plan for them based on our herbs and our nutritionals. So in many cases, the PCOS girls also have high blood pressure. If they're metabolic syndrome, then they may experience also non-alcoholic fatty liver disease and fully developed metabolic syndrome as well. So we need to be investigating into these thoroughly. Insulin resistance and hyperinsulinemia can be a feature. And this is often also observed in women that are lean in addition to those who are obese. So just because they are not showing us, with their body type and shape that they're overweight, we can't not investigate the metabolic syndrome components. Okay, now glucose levels can be normal, but you can see elevated circulating insulin. So we need to do a glucose screening and preferably a 2-hour glucose tolerance test, including insulin, to truly see the snapshot properly of metabolic syndrome. So insulin levels should always be thoroughly investigated. Now, for those patients who are overweight and have obesity, especially central obesity, have a higher risk of polycystic ovarian syndrome. In one study, 50% of PCOS patients were diagnosed as obese, 30% were overweight, and 20% were in a normal weight range. 31% of the obese women had fatty liver, and no cases of fatty liver were seen in the non-obese women. Blood pressure, blood glucose and insulin and elevated cholesterol and triglycerides were also seen in the PCOS obese patients in this study, with an increased incidence of fatty liver. And women with PCOS that are obese have a higher risk of hypertension and then increased oxidative stress and shortage of antioxidant capacity, which puts them then at further risk of complications such as anxiety and depression due to neuroinflammation, and of course a higher risk of cardiovascular disease. Let's come back to looking at insulin resistance in PCOS. So essentially what we're looking at is dysfunctional white adipose tissue, and this has been identified as the biggest driver of insulin resistance in PCOS. We've got to remember that white adipose tissue must be considered like an endocrine gland. Adipose tissue is incredibly powerful at pumping out inflammatory mediators and oxidative stressors and disrupting hormones terrifically. We also know that environmental toxins and xenoestrogens and all of our environmental endocrine disruptors play a big role in disrupting adipose tissue. So these need to be cleaned up through very good and thorough detoxification strategies, because they essentially change our genetics and impact our epigenetic factors in our body, which makes it, relevant to metabolic syndromes. So genetic variants in melatonin receptors have also been linked to an increased risk of development of PCOS due to impairment of insulin secretion and increases in fasting glucose levels. So this is a really interesting interplay between stress, sleep quality, genetic variants in melatonin receptors, and then increased risks of PCOS and metabolic syndrome. Now, I won't go into this slide in depth. However, I think this is just a really good visual demonstration of how metabolically active white adipose tissue is. And what I really want to point out to you is up here that we can see white adipose tissue pumps out inflammatory mediators, activates our macrophages, causes dysregulation with our immune system. So it's incredibly important for polycystic ovarian syndrome to have weight loss strategies if they are in a higher BMI category, to be able to reduce all these inflammatory mediators like interleukin-1, interleukin-6, C-reactive protein, and a host of others, and TNF-alpha, and then normalise the immune system so that we don't get subsequent immunological impacts of metabolic syndrome. So all I want you to take away from this slide is the fact that adipose tissue is incredibly metabolically active, and adipose tissue pumps out a lot of very dangerous inflammatory mediators, so putting our whole health at risk. We also know with polycystic ovarian syndrome, researchers identified that these girls are at higher risk of non-alcoholic fatty liver disease. This is driven by the insulin resistance coupled with the elevated androgens, and then the impact of all them the inflammatory mediators produced by that white adipose tissue, playing a big role in the development and the progression of this disorder. So high androgens is a very high risk factor for the concomitant non-alcoholic fatty liver disease, independent of obesity and insulin resistance. So it's critically important we work hard to reduce the elevated androgens as a key feature of the polycystic ovarian syndrome. We know absolutely that non-alcoholic fatty liver disease is associated with a higher risk of cardiovascular disease in anyone, but particularly the PCOS girls. Now, it concerns me greatly that PCOS is also associated with higher pregnancy risks. So PCOS girls going into pregnancy have a higher risk of gestational diabetes, gestational hypertension. Couple those together and you've got a higher risk of preeclampsia, which is a higher risk then of preterm birth and C-section delivery and complications postpartum for both mother and baby. PCOS is also associated with higher risks of miscarriage, preterm delivery, C-section, and also perinatal death. So these girls who wish to go on to conceive need to do very thorough preconception care for at least 4 months prior to conceiving, to allow them the best opportunity to correct the underlying drivers of their polycystic ovarian syndrome to mitigate risks of complications in pregnancy. So obesity increases the risk of gestational diabetes, hypertension in pregnancy. Obesity also growth restricts babies in utero as well. It reduces microcirculation and therefore, the little baby's availability to good oxygen and nutrients in utero. And we know that obesity increases risks of congenital abnormalities in the children as well. So obesity and inflammation needs to be treated in the preconceptual period. One of the very sad things from an epigenetics point of view is the effects of obesity in the mother are not limited to the maternal health. Obesity in mum also programs pathophysiologically the endocrine system of the baby. And the children born of obese mothers have an increased risk of developing cardiometabolic disease in childhood and through adulthood. So we can see epigenetics play out in a very negative way here. Okay, so essentially the etiology of polycystic ovarian syndrome is still not well understood. It is very multifactorial. There's a very strong genetic trend in families, which does suggest that there's an underlying genetic basis. We know that something that standard medicine doesn't take into consideration is what to do about the chronicity of the inflammation and oxidative stress. Is that a cause or is that an effect of the metabolic derangement? But we see always elevated pro-inflammatory cytokines and a high C-reactive protein. But from an integrated medicine perspective and a holistic approach, we know that we really have a big responsibility to correct body weight, correct ovarian function, reduce androgens, and reduce inflammation while supporting the hypothalamic pituitary pancreatic axis and breaking through any metabolic syndrome dysfunctions. Okay, here's a lovely patient education slide that I've put in for you, which helps to understand just the flow of some of the hormonal impacts of polycystic ovarian syndrome. So we know that the adrenals pump out DHEA. DHEA is often elevated in polycystic ovarian syndrome. Then that needs to go through the aromatase pathway and the 17-beta hydroxysteroid dehydrogenase pathways, which then can activate the estrogen and activate the androgens, which has impact on the skin, on the adipose tissue, and of course on the ovaries. We see the insulin-like growth factor has an impact on the ovaries. The cysts on the ovaries often will produce androgens, so by worsening the androgenic shift in PCOS patients. Then we've got the metabolic impacts of insulin and increased estrogen dominance and increased testosterone dominance, which drives further inflammation. The liver then dumps and reduces its sex hormone binding globulin, so we have more free and available hormone play out on the cell receptor sites. So as we can see, the hormonal consequences and then the genetics of how the aromatase pathways are working and how 17-beta hydroxysteroid dehydrogenase is functioning plays into the endocrinology of polycystic ovarian syndrome and impacts that altered sex steroid hormone metabolism dramatically. So some common features that we will see associated with PCOS is high androstenedione and high testosterone, high 17-hydroxyprogesterone, high estrogen and estradiol, elevated luteinizing hormone, which is really the pituitary shouting out to the ovaries to say, for goodness sake, can you please ovulate? And the ovaries not responding to the message due to the testosterone dominance. We'll see high DHEA, high DHEAS, elevated insulin, which increases then the further production of more testosterone and leads to a suppression of sex hormone binding globulin. We'll see high insulin and high glucose, not always, but in a vast majority of the cases. And then we will see an elevated level of AMH, which is anti-Mullerian hormone produced by the antral follicles in the ovaries. You see reduced levels or low levels on reference range of sex hormone binding globulin, and this leads to an increased free testosterone, free estrogen, and is inhibited by the high testosterone and the elevated insulin. And we will see very low levels of follicle stimulating hormone being produced. So there's some of the key endocrine features that we would see through blood work. So I want to come back to just explore some of the links between thyroid disorders, particularly Hashimoto's thyroiditis with polycystic ovarian syndrome. So there was a meta-analysis published in 2013 which explored 6 studies and found that there was an increased prevalence of Hashimoto's thyroiditis, a high serum TSH, elevated thyroid antibodies in PCOS patients. So Hashimoto's thyroiditis, so autoimmune underactive thyroid, is more common in patients with polycystic ovarian syndrome, so up to 30% of PCOS patients compared to only 8% in the general population. So I add that to any of my blood testing and workups for any any PCOS patient, so that we can actually explore, is there an autoimmune thyroid link in the case, and do we need to be dealing with that from a clinical perspective? Okay, cardiovascular disease and hypertension, dyslipidemia, insulin resistance are also higher in the PCOS patients and also higher in Hashimoto's patients compared to PCOS patients with normal thyroid. So the thyroid dysfunction may be also a concomitant link in increasing the risk of cardiovascular disease. One of the interesting findings was that vitamin D levels were lower in women with both autoimmune disease and polycystic ovarian syndrome when compared to the PCOS patients that didn't have any autoimmune thyroid disease. So again, check vitamin D levels. Vitamin D is critically important in the management of autoimmune disease, polycystic ovarian syndrome, and metabolic syndrome. Let's just have a quick snapshot and a look at environmental toxicity and the impact on polycystic ovarian syndrome. To be honest with you, the environmental toxicity is almost an 8-hour seminar in itself. There is so much evidence around the man-made environmental toxins and the absolute gross and dire impact it's having on the endocrine systems of we humans, but particularly we women. So studies have found significantly higher serum levels of perfluoridated compounds, PCBs, bisphenol A's, pesticides, herbicides, etc., in women with polycystic ovarian syndrome compared to control groups. So we need to ask the question, is there genetic links to poorer detoxification in these women? Or is it associated with that obesity and the metabolically active white fatty tissue in the body that's having a role in, exacerbating the levels of environmental toxins, because environmental toxins are stored within adipose tissue to try and keep them safe and out of the way in our body. So when we get that adipose tissue being metabolically active and producing all these inflammatory mediators, we need to ask the question, is environmental toxicity driving that? And if so, how do we detoxify it from the body? So high levels of BPA exposure can lead to hyperandrogenism and hyperinsulinemia, which are both linked to polycystic ovarian syndrome. We also need to look at a mother's exposure to these environmental toxins in pregnancy and the epigenetic changes that can occur to the baby, and then the increased risks of polycystic ovarian syndrome and metabolic development in the female offspring. So this is terrifying. And what I can urge you to do is to talk to all of your young female patients about the importance of detoxification strategies, environmental toxin awareness, and how to avoid them, but how to upregulate their body's detoxification of them preconceptually and then gently throughout the course of pregnancy. We have a remarkable opportunity to impact positive change in our next generation of human beings with the information and education and awareness that we have available to us right now. So really the essence of this is teach them where they will find BPAs and bisphenol A and pesticides and herbicides, show them how to avoid them, and show them strategies to detoxify them gently. Okay, so some of the common lab tests that we'll see with PCOS is if they're not getting a period and they're amenorrheic, we've got to rule out pregnancy. So HCG hormone must be checked. Let's check their thyroid thoroughly. We need to look at FSH and LH. FSH will be normal or low in PCOS and LH will be elevated. We look at the FSH to LH ratio. In normal, healthy women, this ratio will be about 1 to 1. We do this on the second or third day of a bleed. That's when the blood draw needs to happen. In perimenopausal women, the ratio will be greater, usually 2 to 1 or 3 to 1. The 3 to 1 ratio is quite suggestive of polycystic ovarian syndrome. So 3 times higher LH to only 1 part FSH is a typical marker of PCOS. Estradiol in PCOS can be normal or elevated. Testosterone is usually elevated. Androstenedione is elevated and SHBG is usually low. AMH or anti-Mullerian hormone is often high in polycystic ovarian syndrome, showing us that there's a feature of cysts on the ovaries. So if you're not familiar with anti-Mullerian hormone is produced by the primordial or antral follicles in the ovaries. So this is a little message to tell us how many antral follicles we have. They often call it the egg counter test because this is often a test done to assess the fertility of young women. When we see elevated AMH, that's an indicator of polycystic ovarian syndrome. And AMH will also be always tested prior to an IVF cycle. And if we see elevated AMH, then this gives these girls a higher chance of an overstimulation, which is very dangerous from an IVF cycle. So AMH is something that's an interesting additional pathology test to run, but particularly of the girls in their reproductive years. Okay, so the lab tests, just to recap, DHEA frequently elevated in PCOS. Prolactin might be normal or mildly elevated, can be mildly elevated to chronic estrogen exposure. The other thing that can elevate prolactin is cortisol or persistent stress. Stress has a very sensitive impact on the prolactin levels from the anterior pituitary. We also want to look at a lipid profile. We'll often see low HDL, which is good cholesterol, high LDL, which is perceived as bad cholesterol, a total high elevated cholesterol and high triglycerides. These are all features of metabolic syndrome. We can often see fasting glucose elevated and fasting insulin elevated, but I think it's always important to do a 2-hour glucose tolerance test for both insulin and glucose to have a look at what's going on in that second hour, because that is often where you will pick up insulin resistance in that second hour test. Other investigations that are common will include a transvaginal ultrasound, used to have a look at the ovaries and look at that cystic feature within the ovaries. Characteristically, if a woman has more than 12 follicles per ovary, with each follicle being less than 10 millimeters in diameter, and the appearance of a pearl necklace almost within the ovaries, these are determinant of cystic ovaries. Laparoscopy may be used to evaluate the ovaries and evaluate the endometrial lining in the uterus. But laparoscopy is a full-blown medical surgical technique, and generally that will only be done if there's suspicion of other diseases such as endometriosis or adenomyosis. And I have seen a good percentage of my female population have both either adenomyosis with PCOS or endometriosis with PCOS, because the drivers for adenomyosis and endometriosis are, again, estrogen dominance, which is a common feature of polycystic ovarian syndrome. Okay, so what can the medical fraternity offer patients with polycystic ovarian syndrome? They say, oh, lifestyle interventions, just go and do some exercise and we'll put you on the oral contraceptive pill and or metformin, the major drug used to treat type 2 diabetes or insulin resistance. So the oral contraceptive pill, however, increases risks of hypertension and cardiovascular disease in young women. So that's not good, given the risks are already elevated with PCOS patients. And metformin has a plethora of side effects. So abdominal pain is experienced in 59% of patients taking metformin, diarrhea, nausea, vomiting, headaches, and mood swings. So often this drug is not as well tolerated as one would anticipate, and women don't feel good on it. There is natural alternatives that we can use and trial prior to the necessitation of metformin, often with excellent success. So our botanical and nutritional strategies are safer with a lower side effect profile to try to see whether we can get good success in regulating glucose and insulin. We've got to remember type 2 diabetes and metabolic syndrome are considered to be diseases of lifestyle and environment. So if we correct diet, if we correct lifestyle, so exercising, sleeping well, mitigating stress, being aware of environmental toxicities and eating well, then we can often treat this disorder just by making better and more informed choices about how we live. Okay, so very few women are satisfied with the pharmaceutical management or the drugs offered to them for PCOS. In a 2001 survey, 99% of women with PCOS expressed a desire for an effective alternative treatment to the pill or fertility drugs. 70% of women with PCOS used complementary medicines in conjunction to medical treatments. So that's a huge percentage of this population really looking for natural options to support them and, would prefer to do natural options than the drugs offered to them. So our major aims of treatment: when a patient is overweight or obese, particularly in the case of insulin resistance, our number one therapeutic goal must be to support their weight loss journey. Secondly, we need to look for and treat metabolic disturbances, so dyslipidemia, insulin resistance, and hyperinsulinemia. So we've got to get to the bottom of the metabolic syndrome. We need to promote a healthy hormonal profile and correct their female reproductive hormones. We need to reduce chronic inflammation. We need to look for and overcome nutritional deficiencies, particularly vitamin D, chromium, magnesium, Bs, and our omega-3s. And we need to take into consideration the impact of stress on the metabolic and hormonal impacts of the body. So correcting the HPA axis, reducing elevated cortisol, and mitigating the additional rogue impact that stress has on our entire endocrine system. So there's a lot of work to do. So where do we start? Well, we need to take a multidisciplinary approach with an emphasis on evidence-based guidelines for the management of PCOS. We've got a lot of great evidence, so achieving this is actually relatively easy. Lifestyle intervention should be our first line treatment. We need to teach women how to eat properly and how to move properly. So diet strategies and exercise strategies. These will go a long way in helping to regulate menstruation and helping correct hormones, reducing inflammation, regulating insulin. But we can also help achieve this with some really good botanical approaches. And there's a strength of evidence for lifestyle intervention based on really good quality clinical trials. So exercising and weight loss is a critical part of polycystic ovarian syndrome management. So let's have a look at how weight management impacts PCOS. With a relatively modest weight loss, say 5% of their body weight, this can improve problems like insulin resistance, high androgens, and reproductive function and fertility dramatically. So a modest weight loss of 5% of their body weight. Weight loss in obese patients can reduce testosterone, androstenedione, reduce DHEA, it can reduce cortisol, and also can reduce the elevated AMH we often see. We've got to remember not exercising and having a metabolically incorrect diet, which is carb loaded, is a biological stressor and can drive high cortisol. Okay, so weight loss strategies, we want to, ensure that they're, walking for 30 to 45 minutes every day, ensuring that they're doing some aerobic training at least twice a week for up to 12 weeks. And clinical studies show if women do moderate supervised aerobic exercise for 12 weeks, it dramatically improved the reproductive outcome via modulation of the adipose tissue. It improved the adipolectin and the AMH. And in anovulatory women, it improved their ovulation rate up to 43.3% of the times and restored healthy menstrual cycles in 56% of cases, just with doing exercise. So the outcomes for weight management programs are absolutely excellent, with the added benefit of helping to support behavioural changes with, when you do exercise, you're more likely to eat well. When you do exercise, you're more likely to feel better with motivation and energy. You feel less anxious, you feel less depressed, you have better cognitive capacity. So exercise plays a critical part, not just in changing the biochemistry for these women, but changing the mental health of these women and really turning them around to stay on program and on plan. So how can we use botanical medicine to support PCOS? We are spoiled for choice with a number of beautiful plant medicines to help these patients. So we want to use adrenal adaptogens to improve our stress response, reduce cortisol, and sharpen the HPA axis, and then subsequently benefit the steroid hormone pathways. We want to use hormonal modulators to normalize LH and FSH, to decrease the elevated androgens, to soften and decrease the elevated estrogens, and boost up and support healthy ovulation and get progesterone to look a lot better. We've got our whole host of hypolipidermic herbs to reduce lipids, to improve cardiovascular status. We've got our hypoglycemics to improve and stabilise glycemic control, optimise pancreatic function, help support healthy weight. We've got our liver herbs to improve cholesterol synthesis and reduce elevated cholesterol, improve cardiovascular status and therefore impact hormonal regulation. And then we've got our lymphatics and anticystics, which can actually help improve detoxification pathways at the same time as help to actually start to manage those cysts on the ovaries. Coleus is one of my favourite herbs to help support women on their weight loss journeys and help them with metabolic syndrome. So in a clinical study here that was published in 2005, the Coleus trial group reported less fatigue, less hunger, and an increased sense of fullness with their regular meals after taking the Coleus. Now, Coleus helped alongside diet management to promote a healthier weight loss and mitigate weight gain in overweight females with apparently no clinical significant side effects. So Coleus helps to create less fatigue, less hunger, and increased fullness alongside a calorie managed balanced diet, therefore helping to promote weight loss. So in conjunction with a low-calorie diet, Coleus also improved serum insulin, helped to reduce insulin resistance and increase the healthy cholesterol HDL. The limited effects of weight loss were observed in this particular trial. However, by helping support lowering insulin and correcting insulin resistance, patients went on to have better glycemic control, which can support a healthier weight loss strategy. So this study was conducted in Victoria and was using an extract containing 25 milligrams of Colliers for Scoli twice a day, and it was given 30 minutes before meals. So it helped to reduce insulin, helped to treat insulin resistance, and increase the healthy HDL cholesterol, simply with the addition of Coleus into their treatment plan. So this all collaborates together to help reduce the risks of metabolic syndrome. One of the other wonderful benefits of Coleus is that it improves thyroid hormone metabolism and secretion. So we've seen that link between a higher risk of particularly Hashimoto's thyroiditis associated with PCOS, and Coleus improves thyroid hormone function and synthesis and action on cell receptor sites. Some of the other major benefits of Coleus: it's an antihypertensive, it's an antiplatelet herb, and it's a general cardiotonic. So really well suited for a PCOS patient, especially one who's aiming to lose weight as a part of their treatment strategy. So a dose of Coleus can be given 1 tablet 2 to 3 times per day. Now, we need to manage the blood glucose and the lipids, and we've got a number of herbs that we know are very successful at achieving this. Gymnema, milk thistle, turmeric, boswellia, resveratrol, black cumin seed, cinnamon, berberine, alongside research nutrients such as chromium, zinc, magnesium, selenium, manganese, and our B vitamin family, particularly B3, B6, and B12. So let's have a look at Gymnema, one of my absolute favourite blood glucose regulating herbs. We know that when we taste Gymnema as a liquid herb, it anaesthetizes the sweet taste buds on the tongue. And if you then taste something sugary, you can't detect any of the sweetness in, for example, sugar at all. It's quite a novel, fun little experiment to do with Gymnema in your office with patients. However, it works so much more deeply than that. Gymnema supported healthy fasting blood glucose levels, glycosylated hemoglobin, glycosylated plasma proteins, serum lipids, and cholesterol. So the doses ranged in clinical trials from 6 to 13 grams per day, and the length of the trials ranged from 1 up to 30 months. But in a 4-week, very successful trial, 2 grams of Gymnema was taken 30 minutes before food, with a very positive impact on fasting and postprandial blood glucose levels. So if we need to control blood glucose and insulin, Gymnema is a very simple and effective strategy. We also saw that in the Gymnema group, we observed a decrease in their body weight, their BMI, their low density lipoproteins, without impacting change in insulin sensitivity. So it improves all of your metabolic syndrome markers. So Gymnema, absolutely incredible herb for getting to work on the metabolic syndrome associated with polycystic ovarian syndrome and helping women on their weight management journey. So the possible and proposed mechanisms of action of Gymnema include regeneration of the pancreatic islet cells, improved insulin sensitivity from the pancreas, delayed absorption of the glucose and modulation of the incretin activity and the incretin mimicking activity. So gymnema leads to better weight management strategies, healthier serum lipids, better regulated insulin and leptin, and better regulated metabolic activity of adipose tissue and reduced liver inflammation when seen with a high-fat diet. So gymnema is an incredibly valuable plant to use as a first-line metabolic syndrome PCOS strategy. Silymarin or milk thistle, one of our absolutely favourite liver protector herbs of Western medicine. It improves glycosylated hemoglobin, fasting blood glucose, blood insulin levels. It helps to regulate dyslipidemia and reduce inflammatory markers such as C-reactive protein and high-sensitive C-reactive protein. So such a humble but powerful plant medicine we have available to us. Let's now talk about the remarkable Ayurvedic herb turmeric. Turmeric's used in both Ayurvedic medicine and Chinese medicine alike, but this clinical trial looked at its use in type 2 diabetes patients compared to controls. They took 2 grams of encapsulated turmeric per day with the equivalent of 46 milligrams of curcumin per capsule, alongside the medical treatment of metformin. They found that it lowered LDL by 9%, lowered LDL and HDL ratio by 16.6%, significantly reduced serum C-reactive protein, reduced plasma MDA, but it had no significant changes in fasting insulin, insulin resistance, glucose or insulin ratio or other lipids compared to the control group of metformin. But what we can see here is our powerful anti-inflammatory and has a really powerful impact on regulating dyslipidemia. So the control group just took metformin compared to the trial group took metformin plus the turmeric alongside. So now we're going to have a look at boswellia. Boswellia is a really powerful anti-inflammatory herb that's really highly appropriate for the inflammation associated with Polycystic Ovarian Syndrome and Metabolic Syndrome patients. So patients took boswellia resin 900 milligrams a day for 6 weeks, maintain their oral hypoglycemic drug regime and diet, and their normal exercise levels. And the boswellia trial group, compared to the placebo, showed improvements in lowering cholesterol, better HDL levels, lower LDL levels, and better control of their liver enzymes. So we can clearly see here the impact of this really incredible anti-inflammatory herb, improving their dyslipidemia and therefore their cardiovascular health associated with type 2 diabetes, which is so commonly linked to polycystic ovarian syndrome. So boswellia, 900 milligrams a day for 6 weeks in a type 2 diabetes trial, decreased blood glucose, increased plasma insulin, and did not change insulin resistance, which was actually increased in the control group. So beautiful herb there, which I'm sure we're all very familiar with using in our clinical practice. So resveratrol, an incredibly powerful anti-inflammatory from the botanical world. So again, this trial looked at type 2 diabetic patients, 250 milligrams of resveratrol a day over the treatment course of 3 months with continued hypoglycemic drugs. Now, the resveratrol and drug group showed a significant reduction in glycosylated hemoglobin, blood pressure, and total cholesterol, compared to not seeing those positive changes simply with the drug regime. So resveratrol showing us here positive impacts on metabolic syndrome. Nigella or black cumin seed. Let's have a look at some of the trials associated with this plant. One trial looked at 20 patients who were very sedentary and they were overweight and female, and they were given a dose of 2 grams of black cumin seed a day over an 8-week trial period. Now, compared to exercise alone, the black cumin and exercise group significantly lowered LDL and raised our protective HDL. Another trial showed reductions in cholesterol, LDL, triglycerides, fasting blood glucose, and glycosylated hemoglobin. So it's a very powerful herb, again, for correcting dyslipidemia alongside exercise to give best clinical outcomes. Cinnamon, one of our famous herbs for blood glucose management, and clinical trials have shown that it significantly lowers fasting blood glucose, and the percentage to which it did that was similar to the results you would get with metformin. So we can almost say cinnamon is Mother Nature's, alternative to metformin for blood glucose regulation. And a beautiful herb, and I know a very popular flavour that people enjoy within the United States. So good quality cinnamon as a liquid herb is absolutely delicious. Studies also show through systemic review and meta-analysis that cinnamon decreases blood glucose and total cholesterol and LDL and triglycerides and modestly raise the protective HDLs. There was a pilot study with women with PCOS over 8 weeks where cinnamon improved insulin sensitivity, insulin treatment. Sorry, I'll start that slide again. There was a 2013 systemic review and meta-analysis that looked at the use of cinnamon and saw positive impacts in decreasing blood glucose, total cholesterol, and LDL and triglycerides, whilst modestly raising protective HDLs. There was another pilot study run with women with PCOS and the treatment use of cinnamon over the course of 8 weeks. And cinnamon improved their insulin sensitivity and their insulin stability compared to the treatment control group. Sorry, I'll do that one again. So cinnamon, a beautiful herb, I'll start again. So in 2013, there was a systemic review and meta-analysis looking at the use of cinnamon as a therapeutic agent, which resulted in decreased blood glucose levels, better cholesterol, lower LDL, and moderately raised protective HDLs. There was another pilot study done in particular PCOS women with cinnamon over 8 weeks, showing better insulin sensitivity compared to the controls with the cinnamon group. There was no changes in BMI or estrogen or testosterone in either group, but we saw better insulin sensitivity, which is a really big win. Okay, so some other exciting trials with cinnamon in type 2 diabetic patients. The dose of 1.8 grams a day over 3 months had a reduced glycosylated hemoglobin. 2 grams a day over 12 weeks showed reduced glycosylated hemoglobin and reduced both systolic and diastolic blood pressure. And then another trial using a higher dose of 2.8 grams per day over 3 months showed reduction in fasting blood glucose, glycosylated hemoglobin, and triglycerides. So I think we'd all agree that we can see some beautiful, significant impacts of a humble and delicious herb. Before we finish on cinnamon, I'd also just like to mention some of my favourite energetic features of this beautiful herb. It's so warming. And in cases of PCOS, in Chinese medicine, they will often say that there's a cold and stagnant uterus. So cinnamon is warming. We can taste that when we actually taste the plant, and encourages warmth in the pelvis and good microcirculation to the pelvis. So will often be seen in Chinese medicine formulas for conditions like PCOS. So it's really beautifully warming to the uterus and promotes good microcirculation in the case of polycystic ovarian syndrome. So there's food for thought from a more energetic perspective on that plant. Now, Schisandra, one of my favourite of the adrenal adaptogens, it's called the 5-flavoured berry. It's an incredible little berry and one that's traditionally used in Chinese medicine. We've really learnt about it from the Chinese medicine system. So I first want to talk about it as an adrenal adaptogen. So as an adrenal adaptogen, Schisandra from clinical trials is shown to give one of the greatest improvements in quality of life It reduces the impacts of high cortisol, mitigates the effects of stress, but also has this incredible action on regulating phase 1 and phase 2 liver metabolism pathways. So it promotes healthy detoxification function from the liver, in addition to healthy liver function, at the same time as helping to mitigate the impacts of high cortisol or stress. So liver support and detoxification metabolism support is highly necessary for PCOS patients to help them clear excess hormones from the body and try and prevent those hormones that are in dominance, like testosterone and estrogen, from recirculating within the body. So Schisandra plays a role in improving their stress response, improving their liver detoxification ability and capacity, at the same time as Schisandra has a really positive impact on calming anxiety and depression, being an adaptogen. So Schisandra is one that I say it promotes a good quality of life from its ability to help regulate hormones, act as an adrenal adaptogen and help mitigate the impacts of stress, and help promote lovely liver function and good mental health. It's a herb that I literally use every day and abundantly in my clinical practice. Now, there's some lovely studies around high-dose berberine for metabolic syndrome. So in this one particular uncontrolled study, there was newly diagnosed MET-SYN patients that were given 90 milligrams of berberine over 3 months. It improved their insulin sensitivity, decreased their BMI, waist circumference, leptin levels, fasting blood glucose and insulin levels, and improved their glycosylated hemoglobin. So there's actually a study being done at one of our universities here in Western Australia. It's called UWA, for patients with genetic familial hyperlipidemia, and they've developed a trial drug from high-dose berberine as the new trial agent, and that clinical trial is showing some very successful preliminary results for genetic familial hypercholesterolemia. So it's a plant that I'm particularly interested in because of its robust results for metabolic syndrome and blood lipid regulation. So there was a trial particularly done with berberine in polycystic ovarian syndrome women where they were given 1,500 milligrams a day for 3 months, and it was compared to metformin. So the trial group did the berberine and then the control group did metformin, and the berberine group got decreased hip-waist ratio, a decreased waist circumference, lowering in total cholesterol, LDL and triglycerides, and increased in the protective HDLs and SHBG compared to the placebo or drug group, which did not see these positive outcomes. So again, another win for natural medicine and berberine in PCOS patients with metabolic syndrome. So our key strategies to support healthy blood glucose and lipid regulation: gymnema 2 to 3 times a day, milk thistle 1 to 2 doses a day, boswellia turmeric, celery seed tablets 2 to 3 times a day, berberine from the plant source philodendron 2 to 3 times a day, black cumin seed 2 to 4 times a day, and then cinnamon as a delicious liquid extract 8 to 12 mils per day. So now let's have a look at some clinical trials around botanical strategies that have shown us evidence to reduce testosterone levels, one of the big clinical features from a hormonal perspective in polycystic ovarian syndrome. So the combinations of white peony and licorice in equal parts, so 1-to-1 ratio, have been shown to lower testosterone levels in women with PCOS. They were given 75 grams daily of the herbal combination, and serum testosterone was significantly reduced after 4 weeks of treatment. In another hyperandrogenism study, they were given 5 to 10 grams a day of a herbal combination of peony and licorice, And again, this reduced serum testosterone. However, it wasn't as significant due to the smaller sample size. But there was a positive outcome in 7 of the 8 participants in the clinical trial. Now, this combination of licorice and peony is a very traditional Chinese medicine combination. So whilst there's a few clinical trials, medically speaking, we've got to take into consideration that there's hundreds of years of traditional use of these plants in Chinese medicine for anovular or irregular menstrual cycles that we now lead to call PCOS. Black cohosh is one of my favourite women's health herbs. And in this randomised trial, black cohosh was used in conjunction with the fertility drug Clomid in women with PCOS trying to conceive. In all 3 studies, pregnancy rates were increased with the combination of Clomid and black cohosh concurrently when compared to Clomid alone. So we can safely use black cohosh alongside Clomid for fertility support. And Clomid is often used as a first-line treatment for girls who are having irregular menstrual cycles who are trying to conceive. Now, in women with PCOS, this clinical trial was done using black cohosh and Clomid over 3 months. Pregnancy rates were higher in the black cohosh group, so at 14% compared to 8% in the Clomid trial group. Now, these results weren't considered to be statistically significant. However, we did see in the trial that the PCOS girls had a lower LH level, which is very positive, in the girls taking the black cohosh versus the girls who were solely taking the Clomid. Anytime we can lower LH, we're giving girls a better chance of a natural ovulation. So from a hormonal balance perspective with polycystic ovarian syndrome, we need to support ovulation and hormonal balance. The 3 key herbs I use are black cohosh, chaste tree, and schisandra. We need to reduce androgen excess, and that will help girls then start ovulating properly. Here we use the trialed combination of equal parts licorice and white peony. And then we need to support the adrenal glands. And the typical profile would be high cortisol and also normal to high DHEA. These girls are feeling tired but wired, that typical phase 2 response. So my favourite herbs to support the hypothalamic pituitary adrenal axis in the PCOS girls are ashwagandha, licorice, Korean ginseng, skullcap, and schisandra. They're just a few of my favourites. Okay, so I want to talk you through a very exciting clinical trial that was done here in Australia for polycystic ovarian syndrome. The woman that designed the trial, her name was Susan Arantz, and she and I worked together many years ago at a beautiful clinic in Sydney called the Jocelyn Centre for Natural Fertility Management. She's gone on to get her PhD and become more of a researcher while still doing some clinical practice in Sydney. But PCOS is her area of passion and specialisation. So she developed a clinical study where she had 122 women aged 18 to 44 years of age with a BMI greater than or equal to 24.5 with a PCOS diagnosis according to the Rotterdam criteria. It was a randomised controlled trial over the course of 3 months, and it explored the effectiveness of a combination of herbal treatment with lifestyle and diet interventions versus the control group just using lifestyle and diet interventions alone. This was a very pragmatic trial because it did reflect, real world conditions, given that you can't 100% control someone's diet or 100% control someone's exercise. So a part of the trial design was that the women chose what type of exercise they were going to do, and could choose what foods they were going to eat as long as it met the macros, which met the trial regulations. So the diet was a low-calorie diet with healthy food choices. Exercise was at least 150 minutes per week, including 90 minutes of aerobic activity. So the clinical trial outlined diet changes set to a specific calorie rate with healthy food choices, exercise 150 minutes a week, including 9 minutes of aerobic activity. And women were helped to construct their own personalised diet and exercise plan with a dietitian and an exercise physiologist, and had access to lifestyle coaches throughout the clinical trial, and were invited to attend supervised exercise sessions throughout the trial. So the botanical part of the clinical trial, so the exercise, diet and lifestyle group plus herbal group, got the inclusion of the herbs cinnamon, licorice, white peony, St. John's wort and tribulus. Now, they were given cinnamon because of the evidence around cinnamon improving blood glucose stability, licorice and peony for the evidence around reducing testosterone levels. St. John's wort was included because of the high concomitants of anxiety and depression in the PCOS cohort of patients. And then Tribulus terrastris was used in the clinical trial to help support a healthy ovulation and improve menstrual cycle regularity. So that's why those herbs are selected as a part of this clinical trial. So compared to the control group, the treatment group had vast improvements in body weight, BMI, waist circumference, blood pressure, improved quality of life, less depression, anxiety and stress, better LH and insulin regulation, reduction in oligomenorrhea. So 32.9% of the women in the Herb Plus trial group achieved regular menstrual cycles with the botanical diet and exercise regime. And interestingly, despite the fact that this was not a fertility clinical trial, pregnancy rates were significantly higher in the herb diet lifestyle group. So 11 women achieved pregnancy compared to only 3 in simply the diet and lifestyle control group. So as I said, it wasn't a fertility clinical study, but wow, look at that. 11 women in the trial conceived naturally during the course of the study. So it goes to show that the herbs are also fantastic fertility enhancers in the subset of women who unfortunately have fertility challenges and often unfortunately go to IVF as an answer to their fertility problems, which is often unsuccessful anyhow. Okay, so herbs reign supreme in regulating cycles and promoting healthy ovulations and healthy metabolic status and helping these women go on to conceive naturally, which is so exciting. So the exercise and diet regulation are very important components of a healthy lifestyle. There is no established cure for polycystic ovarian syndrome, but lifestyle changes have demonstrated significant improvements in symptomatology for these patients. So it's recommended that women with polycystic ovarian syndrome, if they are overweight and have a higher BMI, aim to lose 5 to 10% of their body weight in the first year after diagnosis to improve their clinical outcomes. So we need to, as clinicians, support their weight loss journey. And we can start that with some good detoxification strategies, showing them the evidence from the clinical trial that we've just talked about, helping them figure out what works for them in terms of exercise, how much they need to do, and of course, helping them craft a diet that suits them and suits their lifestyle to help break through insulin resistance. So a healthy body weight is associated with decreased metabolically active visceral fat, which in turn leads to decreased insulin resistance, healthy lipid profiles, and healthy mental health outcomes. So less anxiety and less depression. So to improve those cardiometabolic features of PCOS, it's recommended that 150 minutes of exercise a week, which should include 90 minutes of moderate intensity aerobic activity. When it comes to diet, It doesn't need to be overly complicated. Some of the strategies that work really well is the 8-16 approach to fasting, which is very easy to do. That's got a lot of evidence around helping to break through metabolic syndrome. We need 25 to 30% of the calories coming from healthy fats every day. So wild salmon, wild mackerel, nuts and seeds and flax seeds. We want to decrease our animal fats and processed foods, bump up omega-3s in the diet or through supplementation. And lots of lovely natural plant oils. We want 40% of the calories coming from very low GI carbohydrates per day. So I say carbohydrates need to come from plants, vegetables, fruits, and salads. I generally ask my patients to avoid starches, potato, corn, peas, rice, pasta, bread, etc., and focus more on root vegetables like beetroot, sweet potatoes, pumpkin, or whole grains such as oatmeal as a part of their low GI carbohydrate strategies. But lots of fresh fruits, plenty of fresh vegetables, lots of brassica vegetables in the diet because they have a huge benefit in helping the liver detoxify environmental xenoestrogens and our endogenous hormones. We need 20 to 30% of the calories coming from healthy, organic, grass-fed proteins. So organic chicken, organic eggs, grass-fed red meats, wild fish. And if dairy foods are consumed, I prefer that they be organic and preferably an A2 type of protein coming from goat or sheep. And then we want plenty of fibre through the diet, and we can get 20 to 30 grams of fibre per day by using a beautiful nut and seed mix with a good focus on flax seeds in the diet, oats for breakfast every day. So beautiful porridge made from steel cut oats or birch and mueslis, and then plenty of vegetable fibres coming through the diet. That is the infrastructure that I believe is achievable for long-term management of PCOS, will encourage weight management, will keep people feeling full and satiated, and will correct metabolic syndrome. So, a summary of our PCOS strategies. First of all, we need to achieve weight loss if their BMI is high. From a botanical point of view, first try coleus alongside diet and lifestyle changes. We need to regulate dyslipidemia, insulin resistance, and metabolic syndrome. First try gymnema, and then you could try berberine if you need an additional strategy. Now, we need to support healthy hormonal balance. We can first try chaste tree, Vitex agnus castus, alongside tribulus, white peony, licorice, black cohosh, and schisandra. We want to reduce chronic inflammation associated with metabolic syndrome. We can first try boswellia, turmeric, and ginger. We need to correct any discovered and overt nutritional deficiencies based on blood testing. We need to assess vitamin D, and then our insulin-regulating nutritionals, chromium, magnesium, B complex vitamins, and of course, omega-3s. And then we need to support the hypothalamic pituitary adrenal axis and mitigate the dire consequences of unopposed cortisol and stress. So we can first try ashwagandha, my favourite plant, and then we can go in and support with licorice, Korean ginseng, and skullcap. So as you can see, we have an abundance of clinical strategy that's got a great level of evidence basis behind it to support our PCOS patients. Thank you so much for being with me on this presentation today, and I look forward to talking to you with some fantastic question and answers. Thank you very much.